The theme for this year's series is knowledge to improve the world. I want to start by I'm looking at the list to see if our newest members have arrived yet. We have a couple who I think we're planning to attend today, so I want to go ahead and announce them if I can. I'm looking to see if Tyler Anbinder is here, Professor Emeritus of History. He's not. Prabir is here. Is Prabir here? Prabir Bakshi, Professor Emeritus of Decision Sciences. Michael King, I saw his microphone on, but his camera was off. Professor Emeritus of Chemistry. And I'm gonna scan the rest here. I see Jeff Sitch is here, Associate Professor Emeritus of Microbiology, Immunology, and Tropical Medicine. Those look to be our newest members in attendance, so welcome to all of you. The Zoom rules, just in case, if this isn't your first rodeo with us, the Zoom rules are to essentially stay muted. Use the hand raise option if you have questions. Cassandra will be moderating the discussion and keeping a queue of questions, and if necessary, call upon questioners, and they're like, I see Christopher Sten, Professor Emeritus of English, is also here. That's one more. Sorry, I didn't mean to miss you. I'm sort of looking at this and doing it as it goes. So with that, I would encourage you all to use the presenter view. It's easy to see everybody at once, but in presenter view, what will happen is that the presenter, whoever is speaking, gets the focal point and the large portrait in the middle of your screen. So that might be a little bit easier for you all. With that, I want to introduce our host here, President George Bazzini, President of the Society of the Emeriti and Associate Professor of English, to do the honors in introducing today's speaker. And please know that we'll have a prompt stop at 1:25 because both the Dean and I are due at another meeting at 1:30. So with no further ado, George, take it away, my friend. George, you're muted again.
You're unmuted. Now you're okay?
We can hear you, sir.
Okay, thank you. Before I introduce our speaker, I want to announce the passing of one fellow emeritus, Frank Wright, Professor Emeritus of Drawing and Graphics. It is my great pleasure today to introduce our speaker, Dayna Bowen Matthew. She's the Dean of GW's Law School. She came to GW from the University of Virginia Law School in February of this year. At UVA, she was Distinguished Professor of Law and a Research Professor of Civil Liberties and Human Rights. She also served as a Professor of Health Sciences and Director of UVA's Equity Center, an institution she helped found to redress racial and socioeconomic inequality in university communities. Prior to joining the UVA faculty, Dean Matthew served the University of Colorado Law School as a professor, vice dean, and associate dean of academic affairs. In 2018, she received a PhD in health and behavioral sciences from the University of Colorado at Denver. Dean Matthew has a Bachelor of Arts in Economics from Harvard Radcliffe. While studying for her JD in Virginia, she served as editor of the Virginia Law Review. Following graduation, she clerked for Justice John Charles Thomas, the first African-American justice to sit on the Virginia Supreme Court. Dean Matthew is the author of the book, Just Medicine, A Cure for Racial Inequality in American Healthcare, which looks at how implicit bias affects health outcomes. Her presentation today will focus on racial injustices in healthcare. Dean Matthew, my pleasure.
Thank you, President Bazzini, for that excellent summary of my career. I love hearing it and wish that I could record it for my children, who seem not to have the requisite amount of respect for all that it took. Thank you very kindly. I also thank you, Vice Provost Bracy, for the honor of speaking to the Society of Emeriti today and for sharing some of the ideas. I will tell you that I will share some old ideas, and in the tradition of scholarly advancement, I will share some new ideas from a book that's under consideration right now and is due to come out in the fall. So your comments would be welcome in case some of the things that I say raise questions that I should include there. Is it all right if I share my screen in order to put my slides up? Okay.
Yes, please do.
All right, let's make sure I can do that and start my slideshow. All right, tell me if you see what I think is my first slide. Early health lessons, equity lessons from COVID-19. That's my topic for today. I have no financial relationships or conflicts to report. My comments will be organized in 3 parts. I'll go relatively quickly to leave most time for discussion. Part 1, I'll introduce you to health equity, the substantive area of my research. 2, I want to talk about structural racism, the way in which I combine public health information with legal information, and 3, solutions to the problems that I raise. So first, to talk about health equity. If you have any familiarity with the public health field, you've seen this meme. It essentially describes the difference between equality and equity. I use it because as a lawyer, of course, I'm concerned with the concept of equality. It's in our founding documents. The Declaration of Independence, of course, said that the reason for this country's founding was because we were seeking to treat all men who are created equal with the same inalienable rights. Of course, we know that at the moment that that was penned, that equality was not yet realized. We have been struggling to realize it and did so by adding the 14th Amendment to the Constitution to define equality. Equality in the 14th Amendment says that all should be treated equally by state and federal government. The public health meme before you distinguishes that concept of equality from equity. So equity is giving people what they need to be equal. If we were to treat every cyclist in this meme equally, we would not achieve equity because some would get an equally sized bicycle, but not an equal opportunity to ride. And so we define health equity as everyone having a fair and just opportunity to be as healthy as possible. We achieve that by removing unjust, avoidable disparities that are barriers to achieving health equity. So one of the things that we can say is that inequality produces inequity, and it's not just in the United States, which is going to be the focus of my comments today, but globally. Inequality, I would suggest, is the greatest threat to health equity in America and globally. So I want to demonstrate this first by looking at our current global pandemic and how it manifests in the United States. This is my mechanism for introducing the concept of structural racism, a fraught phrase, very much in the public discourse, but I'd like to suggest not as frightening as it is important and essential to resolve. So structural racism is manifest in the CDC's cases when we look at them by race. So as of yesterday, there were 7.894 million cases of diagnosed COVID. Of those, they had produced 216,000 deaths. Let's just hold that in abeyance and let me build the concept of structural racism. Structural racism is a version of structural inequality. We're very, very easily able to show that structural inequality produces bad health. How? Well, we have a composite Gini index, which is often used to evaluate by the World Bank the distance or the difference between the lowest quintile of a society and the highest quintile, their income, their wealth, their purchasing power. When we do that, we have a Gini index, and that Gini index can be described for any locality, for countries, let's say. That's what's shown on the left side of this slide. When you look on the right side of the slide, what you've seen is a cross-tabulation of the Gini index for OECD countries and their health gradient. So the health gradient is an index that was formulated by looking at 10 health outcomes and comparing them to the inequality of countries along this axis. You'll see that there is a direct relationship distribution of countries that are low inequality, that means they would have a low Gini index, also tend to have better health outcomes according to this index of health and social problems. On the other end of the spectrum, you see I have an arrow showing that the United States is a distinct outlier, having both very high distance, great differences in equality according to the measure that the World Bank uses called the Gini index, and that is correlated with much worse health outcomes. All right, that relationship between inequality that is structural, that is meaning you can find it in various forms or institutions in a society, is correlated with poor health. So we define structural inequality by saying that it's institutional. It exists in families, governments, economies, criminal justice, different domains in a society. It establishes and organizes the opportunities that people have in that society. It stratifies the rewards that are available and stabilizes the maldistribution of those rewards to produce the outcomes shown on my prior graph. When those structural inequalities are racialized, then the rewards of a society, as well as the burdens of a society, are also distributed according to race. Again, using COVID-19 as the exemplar. If you go to the CDC website today, you'll find these data showing the distribution by race and ethnicity of the cases, hospitalizations, and deaths due to COVID. That is stratifying by race and ethnicity, the data that I opened this section with. Just pausing for a moment to appreciate that, for example, when we look at hospitalizations, the first column in this display, it immediately stands out that if we look only at American Indian, Alaska Native, and non-Hispanic populations, they have a 5.3 times higher hospitalization rate than whites in America. Hispanic and Latino people have a 4.6 times higher hospitalization rate. Black and African Americans have a 4.7 times higher hospitalization rate. And you see that the death rates, using whites as a reference group, are also disparately distributed. So then let me show you what I would suggest is an operational definition of not just structural inequality, but structural racism. Now to do that, I'm going to have to be able to advance my slide, and I seem to have frozen. I'm not sure I can do that. Let me try this way. Well, I'm going to end the show and start again to see if that helps us, and I can't do that either. Can you hear me? Chris, can you hear me?
Yes, we can hear you.
Okay, so you can hear me, but I can't advance my slides, it would appear. And I'm sorry about that. So I'm going to have to, and I also, let me see if I stop sharing, will I be able to go out and come in? I apologize for this technical difficulty. I think it's far beyond my control.
Yeah, it looks like a Zoom related problem, Dayna, because your video is also frozen. So
Yes.
Okay, so I'll just keep talking.
yeah, you can talk, but your video is frozen. You might want to turn off your camera to maximize your bandwidth.
Okay.
That might be also what's going on.
Do that. It appears that it is Zoom related, but even my cursor won't let me get to. So you're going to have to look at the side of my head with probably a ridiculous look on my face at that.
Oh, we just lost your audio.
Let me see if I can stop her sharing screen on my end.
Cassandra, I'm just going to text her and tell her to log out and log back in. That might do it too.
Okay. I think she just did that. Let's see.
You can sing for us, Cassandra.
No, I don't want to break anybody's eardrums.
Yeah, she's going to be rejoining on her laptop shortly. I just
Okay.
told her to log out and log back in.
Yeah.
How do they do comparisons between a country like Sweden, which is largely of one race, and a country like the United States, which is multiracial?
Yeah, that's always, whenever you see these cross-national comparisons, that's something to always keep in mind that, the United States is the most diverse civilization on the planet. And these homogeneous societies, it's often apples to oranges comparisons because they just simply don't have comparable demography.
You could look at Brazil, I suppose, and Israel, and maybe increasingly Britain, but surely not the countries that Trump loves the most. I mean, he wants more Scandinavia.
Right. Or Japan for that. For that matter. Japan.
And of course, that is a very racist country. I mean, that's so much so that they hate the Koreans.
Right.
Yeah. So
Here she is.
Huh?
Okay.
She's
back.
joining.
Uh-huh. Okay. All right. I'm not going to ask my money back. If I were a student at GW, I'd want a 10% discount on tuition.
You would have already had a petition out going around, right? We would have had 29 signatories. Okay, she's still muted.
There we go.
I'm back.
All right.
I apologize. Now, if you guys are like the students I talked to last night, you want all your tuition back. You want to make sure that that I take the blame for that, and I apologize. Let me tell you, I'm going to just proceed without slides. We're just going to have to do this as a conversation. I'm on my laptop now because my computer went down completely. I was at the point in my presentation where I was going to define for you what structural racism is. Again, it's a fraught term and I really want to unpack it. It's a version of structural inequality that is highly racialized. That is to say, it is a system. This is very different from racism, that is an individual attitude or bigotry or prejudice, right? So it is a system that does two things in a society. Number one, it orders people hierarchically by something we call race, which is a social construct, has no biological meaning in fact, but it is a social construct. So we hierarchically determine that some are at the top and some are at the bottom of a society. And then secondly, we distribute resources, opportunity, and power according to that hierarchy, right? And as a result, outcomes such as the COVID data I suggested or showed you when I had slides up will distribute themselves by race also unevenly. Now, why is this called structural? Well, COVID is the perfect example of why this is called structural, because it is the institutional distribution of resources that affect health outcomes that have produced the racial disparity in morbidity and mortality in COVID. So the resources needed in order to avoid exposure to COVID would include, for example, the type of jobs that we have, right? We need not go out of our homes. We need not get onto public transportation. We need not to enter into crowded public spaces in order to not only do our jobs, but to keep our jobs, right? Disproportionately, those who have to instead leave their homes, go to public transportation, and who are at risk of losing their jobs are racially concentrated among African American, Native American, and Latino Americans in the United States. That means that the structures that organize our employment are a part of the reason that the disease is disproportionately affecting minority populations. Here's another structure. In order to avoid exposure to COVID, especially in the early months, March, April, May, in order to avoid exposure, one needed to live in the kind of houses that most of us live in, right? Single family homes or condos in places that are generously littered with recreational areas. We have the ability to not have to ride elevators generally, and we're able to live in very comfortable housing. As a result, we don't have the exposure to common spaces that put us at risk. We don't have structural defects in our housing. We don't have mold. We don't have allergens in our carpet. Our balconies aren't broken. We have safe, decent housing. We have good employment. We have good income. We have the ability to shelter in place. All of these are structural distributions, right? If I had my slides, the last thing I would show you, or the second to last thing I would show you, is a photograph. If you remember the movie Sully, right? I'm from New York City, and so I remember not only the movie, but the occasion when Flight 1549, US Air Flight 1549, landed on the Hudson River in January, right? The Hudson River in January is not conducive for life for the 155 souls that were on board that plane. So if you looked at a photograph taken of those people immediately after they exited the plane, and you know from the story that the captain was the last person off and everybody got saved. And so it's a wonderful example because it's a feel-good story. But if you look at the photograph, what you would see exhibited is my illustration of structural racism in this way. Most of the people that are outside on the plane are on the wing of the plane, standing with their ankles in the Hudson River as the wing goes down. There is a small group in the photograph that are in life rafts on both sides of the plane. Why are they so much better situated in this emergency than those who were sitting in the back of the plane? Well, because place matters. Your place on the plane matters to your life chances. Structural racism is exactly the same way, and COVID is the exemplar. Your place in society, in our economy, in our housing market matters to your life chances in an emergency like a global pandemic such as COVID. This is the story of structural racism. For the end of my presentation, I turn to solutions. Structural racism is historically constructed by law. That's very important, and it's the message of my newest book. The way in which we have distributed the resources, if you remember the definition I gave you, the resources, the opportunity, the power in the society is fundamentally grounded in law because it has distributed all of the legal determinants and social determinants of health, right? Or it has failed to correct a racially divisive distribution. Two examples, right? So housing segregation was legally constructed really by law starting in about the 1900s. Immediately after the Civil War, during Reconstruction, people lived where they wanted in most cities, right? But Matthew Denton and others have researched carefully that beginning in about 1900, places such as the one I just left, Charlottesville, passed segregation ordinances by law. So what happens? People have to get up and move from their neighbors of a different race and buy houses according to this new ordinance that segregates those people by law. All right, we don't have any trouble remembering that this was the legal regime right up through at least 1954, separate but equal, Jim Crow. We segregated by law, not just residences, schools, hospitals. By golly, we segregated cemeteries. Who could understand why, but we did. After you die, Black people have to go there, white people have to go there, Native people have to go there. We did it for circuses, right? All right, so 1954, you think it's all over, but if you're familiar with Richard Rothstein's book, The Color of Law, you know that law perpetuated these differences, right? The GI Bill, the way that we were able to take advantage of federal home loans, right? Redlining, all of this continued to perpetuate. And so you're following me, this is by law. During the civil rights movement, we had lots of legal remedies, Title VI, Title VII for employment, the Fair Housing Act, the Voting Rights Act, signature large civil rights bills. The last slide I would show you is that during that brief period when the Civil Rights Act was enforced well, we saw a shrink in the difference in health outcomes, adverse health outcomes between Blacks and whites. But alas, by 2001, the Supreme Court began to reverse these civil rights laws. And the evidence of my book shows that we also see a reversal in the progress that we made shrinking the health gap. So we're back in the position now, I argue, that by law, structural racism is now re-emerging. And the evidence, the canary in the gold mine, if I may, is the morbidity and mortality gaps that we are experiencing during COVID-19. The solution is to improve the law. The solution is to get serious about equality and the representations that we have in our Constitution, that all should have an equal opportunity to be healthy in the United States. That is a necessary but not sufficient solution. We will not, by simply changing the law, equalize the burden of a pandemic. But it is, as I said, necessary and important as a first step. So I welcome your comments, even though I was unable to give you much visual support for my argument. I hope you got it.
Thank you, Dean Matthew. At this time, we are going to begin our Q&A portion. In order to do so, we ask that you either use the raise hand option or type your question in the comment section, and I will call upon you to unmute yourself and ask a question.
Cassandra, Steve has his hands up.
Steve, which Steve? Trachtenberg?
Yep.
Okay. Steve, if you want to go,
Yep.
there you go.
Which is more consequential, race or socioeconomic standing?
They're both consequential, but they work independently. Thank you for the question. Here's my example. We have a lot of data that says that infant mortality has been improving in the United States since we started collecting that data in about 1910. It's improved for Blacks, it's improved for whites. However, the data tells us two things that prove that it is not just socioeconomic status, but race qua race, that is race in its own right, that is responsible for the fact that the actual difference between rates and infant mortality on average across the United States are not very much different today than they were in the 1900s. Moreover, even though Black women will lose their children in the first year of life approximately 2.5 times more frequently on average than white women, if I control for socioeconomic status as measured by two things, educational achievement
Yes.
and income, I do not remove that disparity. So that take the state of Colorado, for example. I just do that data for one state.
Yes.
I can do it for 50, to be honest. An African-American woman who is middle class, that is making between $50,000 and $75,000 a year, and who has a college education, is still 2.5 times more likely to lose her child in the first year of life than a white woman who has an 8th grade education and lives below the poverty line. That can be replicated in many areas. The next one that is really heartbreaking is maternal health mortality. But you see what I mean, that race in its own right is responsible as a predictor. It correlates with these disparities in a way that is not erased by socioeconomic status.
Why?
Lots of reasons, we think. In part because there's a fair amount of data that what we're measuring when we see race differences is actually differences in racism. That is the effect of a society on a population based on their race, not just because of the race as and you heard me say this earlier, as a biological concept. So there's a researcher named Arlen Geronimus at Johns Hopkins who's come up with something called the weathering hypothesis. The weathering hypothesis suggests that no matter where my economic status is, no matter where my educational status is, there is a biological impact. We call it measured by the allostatic load. There's a biological impact of weathering the microaggressions of racism, right? And we have a fair amount of data to suggest this, right? So we can tell that, for example, geographically, if we locate a police officer's killing of an unarmed Black person geographically. Jacob Axt has drawn concentric circles around that event and been able to measure differences in depression, anxiety, self-reported health, and over a long enough term, other biological differences or physiological differences like the incidence of heart disease. Proximate to that event, African Americans, Latinx Americans have worse health. It improves as one removes geographically farther away, and it's not replicated among whites. Why? The burden and stress of reacting to a proximate danger that you as an African American person can identify with could expose yourself to by merely walking on the street. It has a physiological impact, and it's part of this weathering, if you will. So that is universally shared, no matter what income or educational status you have. Your race, qua race, exposes you to having to weather, and therefore those morbidity and mortality outcomes will affect no matter socioeconomic status.
Arnie, you can go ahead and unmute yourself with your question.
Thank you so much for permitting me to ask. First out is congratulations on your appointment as Dean. It's a pleasure to have growth of the university. And also thank you so much for your cogent talk. Let me state by way of full disclosure, I'm from the medical school. And so what I'd like.
All right, this has been wonderful. I've enjoyed visiting with you. Goodbye.
There are two issues. Number one, obviously, this is a disease that is not brought about by IV drug abuse. It's not brought about by sex, dirty water, or mosquitoes, and so forth. This is human-to-human contact in one form or another, droplets, aerosols, and so forth. So I'm wondering if your analysis also plays the same in other diseases like COVID that are droplet infections, like influenza, tuberculosis, and so forth. And could you also comment on things, medicine is very plagued with the whole notion of racism because it's a surrogate marker for genes and so forth. And it's a very bad surrogate marker. And the perfect example is East-West Africa and so forth. They're totally, totally different, even though people have certain pigmentations and so forth. So I'm curious about the second question, sort of in the notion of, do you see this in other types of conditions, is what we call just genetic susceptibility. Mm-hmm. For some terrible reason, women in this country, African-American women, tend to do much worse in breast cancer than white women. Some of that may be, as you're talking, institutional racism, but some of them might be biologic. Mm-hmm. I wonder how you factor that in. So thank you so much, and I'll mute myself to listen.
Wonderful questions. I'm going to take them in turn. First, let me reference you to a concept of social determinants of health, right? Social determinants of health, I'm sure, is familiar to Dr. Schwartz, and I wanted to introduce it to the group. This is the concept that health is much more determined by social constructs like structural racism, I'm suggesting, than by genetic, biological, or even access to clinical care, right? In 1999, Tarlov et al. Started a conversation, if you will, on how to quantify the extent to which each of these determinants produced health. And the current thinking is generally around these estimates. 10% of your health is determined by your genetic background. 10%. 10% of your health is actually determined by your access to clinical care. 10%. More like 30% is attributable to your health behavior. We can have a long conversation about that. I'll skip it right now to make sure that I'm on your question precisely. And another 40% is from your social, environmental, including structural racism context. That's why that plain story, that's why place matters. It matters 40%, right? So certainly, Dr. Schwartz, I could not say that the evidence does not support that there is a genetic component, but as you well know, and I would be far out of my depth to try and converse much further than this, there's more variability between people in one racial category than there is among people from one to another racial category, right? So that genetic variability is not a great explanator, if you will, for the disparities in health outcomes that we're describing. Now, to the second part of your question, do we see it elsewhere? Unfortunately, sadly, we see it everywhere, right? So not only COVID data, I use COVID data because it's a very present and poignant example today, but let's see, starting with a consensus report from then the Institute of Medicine, now the National Academies of Health, there was a report called Unequal Health. Unequal treatment, excuse me. Unequal treatment, 2003 consensus report. And it gathered 600 peer-reviewed studies in various different medical settings. So private practice, publicly insured patients, large health systems, federally qualified clinics, and so forth. And in not only several different health delivery settings, but also for several different disease modalities. So heart disease, best data we have. Cancer, stroke, death due to lung disease, for example, and a large distribution or manifestation of different disease. And the general finding was that race and ethnicity predicted not only prevalence and incidence of health outcome, but also access to the quality of care that we could consider optimal. That was the start of a conversation in 2003 that began, and this data has been replicated copiously, began research that showed across many different disease modalities, many different health status, many different settings of healthcare delivery. African Americans, Latino Americans, Asian Americans to a much lesser extent. And in fact, there are some diseases in which we have crossed the line for Asian Americans and for Latino Americans. And Native Americans have generally had the same disproportionate morbidity and mortality that I showed with respect to COVID. Why? I think the biggest reason, the biggest explanator is because of that 40%, right? If we are correct that 40% of health outcomes are informed by your social economic environment, the fact that we have as a society structurally distributed the worst social settings, the worst or least advantageous access to healthy environments to people of color is the reason, the determinant that we see that across so many different modalities. We're making progress in some. Diabetes is an example, some forms of cancer, another example, but as a general proposition, bad health is racialized in this country.
Our next question is from one of our new members, Professor Richard Ruth. If you'd like to unmute yourself, the floor is yours.
Thank you very much. And thank you, Dean, for a brilliant and very important talk. I'm a clinical psychologist and I'm Latinx, and I see the same problems you describe accurately as being in the forefront. I approach them from a different position as a healthcare provider. And as someone who thinks not just about healthcare encounters, but healthcare systems. I'm curious about your perspective on what kind of dialogue between healthcare systems, healthcare professions, healthcare providers, law, and public health you see as holding potential to make a meaningful difference in defeating structural racism and possibly other structural inequalities as well. The specific that I have in mind is that I've experienced health systems who hear that the problems are legal, the problems are structural, and channel their resources in ways that do not capture the depth and the edge of what you're saying. And well, let's have programs to get people to walk, you know, or let's give people videos about better diet. And the access to actual healthcare, where an encounter can bring a committed, conscious provider and patient to say, how is structural racism affecting you? What do we do about it? How do we mobilize together? That's what I'm thinking about, and I would very much value your thoughts.
Thank you so much, Dr. Ruth, for the question. I will tell you that this is a conversation that I hope to occupy the rest of my career. And the reason I came to GW Law, the reason I'm proud to be a member of the George Washington University community is because of the opportunity to have the exact kind of cross-disciplinary conversations about solutions that your question invites. So I'm going to touch the tip of the iceberg and hope that we could continue the conversation. We need a healthcare delivery model that really does reckon with the social determinants of health in a structural way. What you described as the interventions that I'm sure frustrate you as they do me are interventions which belong on the very tip of the iceberg, I've chosen that advisedly, of something we call the health impact pyramid. If you remember, Tom Frieden was for a time the head of the CDC. He is the author of a conceptual framework called the health impact pyramid. At the top of the pyramid are the kinds of interventions that you, Dr. Ruth, have described for any given health problem: health inequality, structural racism. And they go to the least impactful but easiest to implement types of interventions. I know what we'll do. We'll give people brochures. I'm not saying that brochures are unimportant. They're just unlikely to impact anything structural whatsoever. I know what we'll do. We'll educate people. We'll make a just say no campaign, or we'll aim at individual behaviors. That's the tip of the iceberg. It has no structural import whatsoever. Not useless, but very likely to do little to change the structural problem and distributions that we've been talking about. At the bottom of the pyramid are structural solutions, We change the context in which people get the water that they drink, and therefore we see fluoridation improves their outcomes, right? That's a public health intervention. We connect school attendance, boy, I'm going to open a can of worms here, with vaccination so that we structurally change herd immunity and make sure that populations go to school healthy, and we change the incidence of smallpox and other diseases. You see what I mean by structural changes, right? In order to address structural determinants of health, social determinants of health, we need a healthcare system that actually screens for structural determinants of health, right? A health and physical, an H&P, should include questions about your security and housing, your access and security to food. It should include integrated care that not only delivers the clinical care, but addresses the social barriers to that clinical care. Here's my last example, and you'll see why. The delivery models have to change. Health systems have to change, Dr. Schwartz, in the way that they actually treat patients. Take asthma, which is prevalent among Black children in ways that are wildly disproportionate and controllable. This is what I mean by unjust and unfair, right? You give a Black child, you give any child, doesn't matter their race, you give any child albuterol in order to treat their asthma, you send them home, and the child who is Black and poor goes home to an apartment that is moldy, that's pest infested, that has allergens in the carpet, and that albuterol does not stand a chance of helping that child recover. When we see the disproportionate representation of Black children in housing that is substandard of that nature, we also see a correlation in their disproportionate share of exposure to a prevalence or incidence of asthma, right? The healthcare system has to begin to embrace that if you want healthy children, you have to integrate not only the delivery of healthcare, but also the delivery of partnering with housing that will collaborate with and cooperate with that healthcare, otherwise the healthcare working alone will not work, right? So you have to screen for the problem. Then the healthcare provider has to collaborate, and there are many examples of these. Unfortunately, they're isolated, but there are many examples of places that screen for substandard housing and partner, Louisiana, North Carolina, believe it or not, Pennsylvania, where the Department of Health and the Department of Housing are collaborating and breaking down reimbursement structures so that when healthcare finds that housing is competing unfavorably with a health intervention, they can cross the boundaries of those two distinct and otherwise unrelated areas of government, and they can provide supportive housing and have not only healthcare delivery, but housing and contextualized environmental changes as part of healthcare. Now, I have lots of other interventions. That's an easy one. One of my favorites is there's a federally qualified health center in Brockton, Massachusetts. If I hit the lottery, I would pay every federally qualified health center in the country to do just this. They have co-located with a supermarket, and that supermarket is not only right next door, but is culturally appropriate. It's in a Cape Verdean neighborhood, so they sell Cape Verdean food, right? Patients have to agree, but diabetes patients who agree, instead of having their one-on-one well checks, have their their basic regular checkups in groups of 8. So they come to the federally qualified health center, they have their individualized questionnaires, whatever information is required in order to check their A1 status and the things that are important to medical clinicians. But they, in that group of 8, are also sitting in the middle of a test kitchen built into the federally qualified health center. And the lesson for the day for the group is how to make, fill in the blank, some recipe that is high in the kinds of nutrients that will help people change their diet and improve their diabetic outcomes. And they then get a prescription for the food that they need to make as a result of their lesson. They walk out the door of the clinic, into the door of the very conveniently located grocer, and they hand their food prescription and go home with food that will help them be more healthy, right? This is the new way we have to think about delivering healthcare. If we are going to take seriously the fact that social determinants are responsible for 40% of health outcomes, we cannot continue to do business in the same old way and think that because we change the way somebody walks or the way they sit on their couch a little bit less, that we're actually going to make a dent in the population health. So the moral of the story is that we really need to educate and implement our health delivery systems in public health interventions, population health interventions, preventative interventions that take into context and take into consideration seriously the social determinants of health and their maldistribution.
I think we have time for one more quick question. If anybody has one, raise your hand. And okay, go ahead, Dr. Dyer. Go ahead and unmute yourself.
Enjoyed your presentation so much, and I can attest that you were equally compelling whether you did it in the PowerPoint version or you talked to your slides. I mean, it was really magnificent the way you carried forth, and it was just as good, I'll assure you. But I would like to have access to the slides. This is a quick and maybe easy question. If we were able to change the circumstance of a significant cohort of African Americans, one change in circumstance might be occupation. So we'll study the mortality rates, the disease proneness of African Americans who have joined the military and been in the military for a career, US military. Or we could look at African Americans who have gone elsewhere. Take almost any country in Northern Europe, Germany, Scandinavia, or whatever. Would we see marked differences in all these health behaviors and indicators as compared to the US? And looking at this, these comparative data sets?
I'm going to answer your question this way. It's a great question and one that I don't have a precise answer to because we don't have the data. I think, and please stop me if you think this is too far afield. I think I'm going to answer your question by saying, what could we do? What is the thing that would make the most difference if we were to change one and only one variable for African Americans, whether it's their location, their housing, their insurance, their whatever it is that we can change. So far, the best data is, I think, from two researchers. One is Raj Chetty at Stanford, and the other is Sandro Galeo, and you can write me hate mail because I'm sure I've got that not exactly right. But those two researchers have done enough work for me to answer this way. I think the single most important change, if you wanted to see these health differences change over a generation, is to change the income distribution that disproportionately locates African Americans at the lowest end of the income spectrum and wealth spectrum. Why? You could change so many of the other social determinants of health if income were more equally distributed among the population. Lots of those income distribution changes would have an impact on where people lived, housing, what kind of work they did, what kind of access to healthcare they would have. They would not solve the racism problem, right? The weathering problem that I talked about earlier with respect to Arlen Geronimus's work. But it would change several of the structural differences and allow people to buy better food, to locate away from pollution sources, right? So that I wouldn't be also putting my school-age children in school next to a highway or a 6-lane highway or a landfill. It would allow me to choose neighborhoods where I could find better early childhood education. Education is a huge determinant, and that's the second one right behind income. I can change outcomes for generations if I change access to quality education. When we look at different nations, the last part of your question, Sadly, we don't see much better income distribution among populations that are Black, that is descendants of African, than we do in the United States. The United States is the worst by far, I will say. But we don't see large distributions racially. Racism, last thing I will say, is a problem around the world. It's sometimes called colorism because race is a very uniquely American context. But the last thing I want to leave with you is this: racism hurts Black, white, everybody. Not just socially, not just theoretically, not just in principle, but we have data to show that white people's health is worse where racism is more virulent. Not as much worse, but it's worse, just like Black people's health is worse, right? So I'll leave you with this last set of experiments, one example from it. My personal favorite right now is a researcher who's looking at racism by scraping Twitter and Google data for searches of racial epithets, right? So how often are you looking for the N-word? How often are you typing all lives matter or Black lives matter, right? The density or frequency of those searches are located by county and then correlated with health data like infant mortality, death from cardiovascular disease. And what we see is that although Blacks are more severely affected, the correlations or the beta, if you will, the beta variable is higher for Blacks. Whites have also a correlation of higher death, worse health outcomes in places that have lots of racism defined by these searches, right? So this is a health problem for all of us. And I hope that my research and further conversation with folks like you will begin to address it so that we'll all be better off.
Well, thank you, Dean Matthew, for an amazing talk. I hope you all now see why we selected her to be the Dean of the Law School. She's absolutely tremendous personality, brilliant, and not a bad person to hang out with either. So Dayna, I'm going to let you get out of here because you know we have a faculty meeting in 3 minutes.
Okay, bye-bye. Thank you, everyone. Wish me luck. They're a tougher audience. Bye-bye now.
And for everybody else, a preview of coming attractions. Our next session will be on November 20th with Professor Juste Santos from the School of Engineering. The title of his presentation is Predicting the Ripple Effects of Disasters Across Interdependent Infrastructure and Economic Systems. That is something that we are currently dealing with at this moment. And so we will gain additional insight into the impact of the pandemic. So thank you all for joining us this time, and I hope to see you again on November 20th. And now I'm going to chase after Dayna and jump into that other meeting as well. Take care, everybody.